I want to follow up on medical assistance transportation. There was provision, obviously, the General Assembly passed in the Human Services Code. The governor signed into law to require the department to do an RFA to broker MATP moving forward. There's been an ongoing pilot program in Philadelphia. If I'm not mistaken, there are 46 states who utilize this brokerage model, whether for the entire state or parts of the state. That about correct on the background?
I believe so, yes.
Number one, from the pilot program in the city of Philadelphia and other states, are you aware of anyone getting kicked off the bus and having to walk to their treatments with a broker model?
No, we're not.
Okay. What does the data show for the brokering of Philadelphia versus the rest of the state?
So it's a little different in terms of how it's administered. So under the rest of the state, we are providing it as an administrative service. So in those instances, we are paying a per trip rate, and we're drawing down a different federal match at 50%, versus in Philadelphia, where we're setting a per member per month rate for those trips, and it's claimed as a service match. So there's a difference in the match that we're receiving. So it's not really an apples to apples comparison that we can make, but I can say that in the analysis that we've done, we believe that by moving to the broker program, we will see some additional savings of close to $10 million.
And then as far as outcomes, what are you seeing in Philadelphia as far as the outcomes? What's the ridership saying about the brokerage in Philadelphia? Has it been a positive response?
Yes, we have not heard that there are issues in the Philadelphia area related to the broker program.
Okay. Are you aware of any negative attributes from brokering MATP in rural areas from the other 46 states that have a brokerage model? I tried to do a Google search of those states, rural. I have not found any negative newspaper reports on any of those states.
We're not aware of anything either.
Okay. You kind of addressed my federal disallowance question earlier, and then can you just kind of give us a brief summary of the status of the RFA? Where is it at? Timing moving forward, implementation, and so forth?
Sure. So the request for application was released on December 21st of last year. We held the pre-proposal conference on January 11th and issued responses to questions on January 28th, and applications are now due on March 19th, 2019. In terms of actual implementation, we are, a couple years out?
Yeah. By the time we need to evaluate, obviously, the response to the applications and then go through our procurement process. So we're anticipating that we likely would not implement until 2021.
So we're a year out from really full implementation. So stakeholders have ample time to work with the department moving forward. And we did have your sister agency, the Department of Transportation. They've reviewed the RFA, they provided comments, and they have a comfort level with it as well.
Yes, we've been working very closely with the Department of Transportation on this and made sure that we've answered their questions, and they did have a chance to review it before it went out. And so, yes, I think we've been working very closely with them and trying to work very closely with stakeholders as well. And as to your point, we will continue to do that as we go forward. Happy to answer questions and continue to remain involved with stakeholders.
2 written requests for these, so I don't need a response now. Number one, how is the CHC coordinating and working with Peer Group 13? Establishments moving forward? I've noted that they've had some concerns with the budget adjustment factor in the past. So just curious how that's rolling out with those organizations. 2, to follow up on Representative Kinsey, some of our hospitals are having issues with finding places for safe discharge for individuals. They're looking at personal care homes as an effective way and a lower cost than keeping them in the hospital. So they're curious about if there's going to be a rebalance or a rebuild of the personal care homes moving forward. One comment, with regulated community, there are some issues with if you have a regulated entity through multiple jurisdictions, different regions, having a equal interpretation of the regulations and not one in the Northeast, one in the South Central. So probably some more work with maybe the regulators and saying, here's our regulation, here's how we're interpreting, and just make it uniform. So there's not a difference in between the two. I've been doing a lot of research on integration. It's very fascinating. Seems like a lot of the research is heading towards coordinating behavioral health and physical health moving forward. I do have a couple studies. NAMI, for instance, in their national policy platform calls for better integration of physical and mental health care, including sharing relevant health indicators. Mental health care providers need to monitor key physical health indicators and the physical effects of medications. Primary care doctors must follow up on physical issues identified. Seton Hall Law did a study for New Jersey on integration of behavioral health and physical health care. Their executive summary cites people with behavioral health conditions suffer from missed health care opportunities. Research has shown that people with serious mental health illness suffer from increased burdens of sickness and early death as a result of poorly managed physical illness. People with less significant behavioral health conditions too often remain unconnected to mental health or substance disorder care because such services are unavailable in primary care settings. Clinicians responding to these systems deficits, advocates, care integration through bringing primary care and behavioral health under one roof. I know our local behavioral health, or our local WellSpan hospital at least, they have integrated care within the model. I just want to get your thoughts on the importance of that and trying to treat the person holistically and any barriers you're facing and towards that goal.
So, I've been asked a lot lately about the carve out, and I've said the same thing over and over, and I'll give you my thoughts for what they're worth. I think 20 years ago, the carve out, I think, made a lot of sense before we had mental health parity laws and when our behavioral health providers were primarily grant funded and contracted through the counties. At that time, I think most behavioral health providers weren't contracted providers within commercial insurance. So I think it made sense to carve it out and make sure that people had access to these services and that the behavioral health providers remained stable while we transitioned to a new delivery system to manage care. I do think a lot has changed in the last 20 years that just provide a good reason for us to take a fresh look at our system and see if we think it's still the best system to ensure that people are getting the behavioral health services that they need and in a timely manner, and that they're getting services that are truly integrated and we're really treating the whole person. There is, as you mentioned, there's certainly a national trend towards integrating these services. I talked to one state recently and asked them, why they decided to integrate and talked a little bit about how they did it. And they said when they dug into their data that they saw, I think you kind of referenced this, they saw that people with serious mental illness in their state were dying 30 years earlier than the rest of the population. And when they looked into it, it wasn't because they weren't getting their behavioral health needs met, it was because they weren't getting their physical health needs met and they had chronic physical conditions that just weren't being addressed. Over the last year or so, I've had an opportunity to meet with a lot of healthcare providers, and one of the themes that I'm starting to hear from them is really related to the challenge that the carve-out presents to some of our more innovative models, where they're doing a really good job of integrating physical and behavioral health, delivering that in a really integrated way, and also doing so in a value-based payment arrangement, which is what we've been pushing from the department's perspective. So I was looking at a model in Pittsburgh not too long ago where they had social workers and primary care providers, they had psychologists, they had everybody in the room that really touches these patients from all different perspectives. And they were really focused on the hardest to serve populations. It was a really exciting model to see. But one of the things that I heard over and over that day was that they really struggled with navigating two separate MCOs with two separate payment mechanisms, and that just makes this model really difficult to sustain because they were very clear that they need a value-based payment method to do what they do, and trying to get two different MCOs on the same page with a value-based payment is just very, very challenging. So I've shared that challenge with stakeholders over the last several months and really encouraged them to help us figure out how we can solve this issue. I've not presented an answer. We have not presented or proposed anything in the budget in terms of addressing this, but I do think we need to determine whether our current system can meet the new challenges today, like the opioid epidemic, or whether we need to update our current system, whatever that update might look like. So this is something that we're continuing to explore. We've been reaching out to other states to kind of learn about how they have how they've integrated to the extent, that might make sense, but just try to explore what's out there, what our options are, because I think at the end of the day, we always have to look at our existing programs and ask ourselves, are they the best they could possibly be, and are people getting the care and the type of care in the way they need to get it? And I think we may have an opportunity to improve our system because we certainly are facing some challenges.
I'd say you do that with your work programs, reinventing that. And I just want to clarify with I know we're out of time, but you said with the PBM changes, the PBMs, the rebates will actually be reverted back to the MCOs?
And then that will be taken into account in our rate setting process.